Started with our webinar today, Building Sustainable Quality Improvement Systems in Your Practice. My name is Kate, and I'm a program manager with the Patient Center Primary Care Institute. And I'm just going to say a couple of things before we get started with the presentation today. So first and foremost, we definitely want to hear from you. So please type your questions into the questions pane at any time during the presentation. We'll have an opportunity to stop and take questions. And so we encourage you to write those in as soon as they come to you. No need to wait until official Q&A time. Asking them as we go along allows me to kind of organize them and get them ready to make the most of our time together today. The one question I know I will get is whether the slides and things will be available after the webinar, and they will be posted to the Institute website along with a recording of this webinar by the end of the day today. So please check back for that if you want to share it with any colleagues. The Institute is a public-private partnership launched in 2012 with the support of the Oregon Health Authority and managed by QCOR. We partner with experts like the folks that are presenting on the webinar today to get technical assistance, information, and resources out to people working on the patient-centered primary care home, or PCPCH, or medical home, if you prefer, model of care. We encourage you to visit our website if you haven't already, or poke around a little bit more if you haven't spent much time on it. There you can access a series of online learning modules about the PCPCH program, recording of more than 20, I believe at this point, webinars that we have done in the past, like this one, on a variety of different topics. And you can also access a series of resources about the PCPCH standards. So Oregon's PCPCH model is defined by 6 core attributes, and within each of those core attributes there are a series of standards the practices attest to become recognized as a patient-centered primary care home by the state. You can learn more about this program on their website at primarycarehome.oregon.gov. And I am very pleased to introduce you to Dr. Gillespie, who is a general pediatrician with the Children's Clinic in Portland and is also the medical director of the Oregon Pediatric Improvement Partnership, which has partnered with the Institute to do a lot of great work in the last couple of years. From 2007 through 2010, he worked as the medical director of quality improvement for the Children's Health Alliance, where he designed and implemented QI projects for a network of 110 pediatricians in the Portland metro area. He is actively involved as a member and advisor to a number of local quality improvement initiatives and state policy committees, including the Patient-Centered Primary Care Home Standards Advisory Committee and the Oregon Health Authority's Metrics and Scoring Committee and the Child and Family Wellbeing Measures Work Group. So we are definitely in good hands, and I will hand things over to you to get us started.
Thank you, Kate, and good morning, everyone. Thanks for joining us today. So our objectives for today, we're going to just talk a little bit about some key factors in practice-level sustainability and spread of quality improvement efforts. We're going to review some concepts related to motivating change amongst members of a practice, which I think really comes down to understanding the personalities within your practice. Understanding some steps for creating a highly functioning quality improvement structure for your practice, and then we're going to turn it over to one of our practices that we've worked with through OPIP, who's done a fantastic job of implementing some of these ideas and have created a sustainable QI structure within their practice so that you can get a little bit more on-the-ground firsthand experience of what that's been like. Before we go into the presentation, I just wanted to kind of ask 2 polling questions. So Anne, if you can start the polling questions, that would be great. And these sort of relate to some specifics about the PCPCH standards that we'll talk about in a second. But first of all, how many of you have a dedicated committee or group that works on quality improvement within your practice? And that's a yes or no kind of question. So we'll give you a minute to answer that one. hopefully everybody's had time to answer that one. Do we have the results on that one, Ann? So about 78% of you do have a dedicated QI committee or group, and about 22% do not, so that's good. Hopefully these slides and the stuff that we talk about will help you to kind of refine what you're doing. And then with the second polling question, again relating to the PCPCH standards, have you recruited parents, patients, or families to work with your practice on quality improvement? And this again is a yes or no. Yes, we have patients or parents working with us on QI, or no, we do not. Okay, so the majority do not. 88% say no, that they do not, and 13% yes, they do. It doesn't quite add up on math, but that's all right. So we're going to talk a little bit about that today, actually a fair amount about that today. I come from the perspective as a pediatrician of recruiting parents in, but I think a lot of the concepts of how you recruit people into your practice will work regardless of whether you're recruiting patients themselves or if you're recruiting parents to work with you. So those two standards that we were talking about, the first one comes out of accountability and has to do with quality improvement. And the concept within the PCPCH standards is that having a formal QI program is an essential component of patient-centered primary care homes. And so you can see the standard as it's written within the PCPCH program. So at the lowest level, a PCPCH is using performance data to identify opportunities for improvement and acting to improve clinical quality, efficiency, and patient experience. The next level is having actually that QI team, so you're utilizing improvement teams that are multidisciplinary and meet regularly to review timely, actionable team-level data related to chosen improvement projects. And then the highest level is that there's a documented clinic-wide improvement strategy that has performance goals derived from community, patient, family, caregiver, and other team feedback, public measures, and other areas for clinical and operational improvement identified by the practice. And the second standard that relates to what we're going to talk about today, again, is the patient and family involvement standard. And the concept there is that the PCPCH actively and formally involves patients and families in efforts to improve services. And at the lowest level, involving patients and caregivers as advisors on at least a quality or safety initiative at least once a year. Middle standard is that there are formal mechanisms to integrate patient, caregiver, and patient-defined family advisors as key members of quality, safety, program development, and or educational improvement activities. And then finally, the patient, caregiver, or patient-defined family advisors are integrated in the PCPCH and function in peer support or training roles. So again, we're going to hit on how these standards can be meaningfully implemented in your practice today. And when I think about sustainable QI systems, I kind of go through three processes in my brain. And the first is understanding how your practice actually does change. And so that gets into understanding the clinic's change culture and knowing how changes are made within a practice, not only in terms of the structure and governance of your practice, but also in terms of the personalities in your practice and who is either a formal or an informal leader within your practice. Communicating project goals, aim statements, and measures to the entire practice, successfully engaging and getting the backing of clinic leadership, and then communicating project goals, aim statements, and measures to patients and families. And the key thought here is that if you understand how your practice typically addresses change and typically addresses decision-making, that will help you to facilitate quality improvement project spread. The second thought is really how you build healthy QI habits as a team. So learning how to develop QI skills as a practice in terms of learning aim statements and PDSA cycles. I'm not going to talk about that today. I'm assuming that you guys already know that. And then interpreting performance measures as a team, which is referred to as sense-making. And then finally, engaging patients and families in QI efforts. And the idea here is that quality improvement skills and knowledge can't live in the brain of a single person within the practice or even a small group of individuals if you're going to sustain change. And really everyone in the practice should have some fundamental understanding of how quality improvement is done in order to be successful as a practice. And that thought actually came from a fairly unpleasant conversation in my practice. I've been leading QI efforts within my practice for about 8 years now. And a few years ago, before we had a formal structure within our practice, one of the providers actually said, well, what are we going to do when RJ's plane goes down? Which, given that I travel a lot for conferences and stuff, there's a probability that that might happen. So it was a little bit of an unpleasant conversation, but certainly the idea was that I can't be the only person responsible for quality improvement in a practice our size. And so really you need to make sure that there's a large enough group of people who can do this work that it's not all dependent on one person, so that if they leave their job or move on to another practice or retire, that you're not left high and dry in terms of being able to continue to do quality improvement within your practice. And then the third thought is really, again, about getting down to creating that durable infrastructure. So how do you form a multidisciplinary team for ongoing QI work? How do you develop a clinic-wide strategic plan for QI? And then how do you create a system for tracking performance measures? And really the idea, again, is that in order to sustain quality improvement long term, you really are going to need to have a permanent infrastructure for QI. And that was the idea behind the PCPCH standard around quality improvement. So we're going to talk first about understanding practice change and intentionally ensuring that you have engagement at a clinic level. And primarily what we're going to talk about is again, how you understand the personalities within your practice and the structures within your practice to know how to make changes happen. Medical home transformation, I think, really needs to be viewed as a flexible and long-term process. Once you've ticked off standards to say that you're a Tier 3 PCPCH medical home, you're generally not done. There's always still things that need to be refined or that need to be adapted or that you need to respond to from external or internal pressures. So how can you build a project team in a way that creates new innovation at the same time that you sustain your quality improvement work? And in terms of understanding the change culture, a few things that I think are important to think about. And first of all is, how are changes made within your practice typically? So if something needs to be implemented or needs to be changed, whether you have that formal structure or not, how does that structure fit into the existing operations of the practice? Second question, who holds decision-making authority within your practice? And I think those first two questions, for me as an example, I work in a practice that has 29 providers altogether. We're divided into 2 sites, each site divided into 4 modules. We are run generally by our board of directors, which is the entire physician population within our practice. We have a smaller group of physicians that form up an executive committee that rotate on a 2-year basis, so they do most of the day-to-day decision-making. But when it comes to big change within the practice, the board of directors has final say in terms of what we actually do. And as you can probably imagine, running an organization of our size with 28 providers and 1 nurse practitioner, there are a lot of big personalities in the practice, and so change can be slow because we try to do things by consensus governance. Third question here, how can you engage other providers to participate in changes made during quality improvement projects? And then finally, what structural supports do you need to maintain continued growth as a medical home? So as I mentioned, in my practice we have 28 providers and 1 nurse 28 physicians and 1 nurse practitioner, so 29 providers altogether. And so generally speaking, again, if you try to understand the personalities within the practice, you can understand the pitfalls that you're going to run into if you're trying to implement a change. So for example, if somebody in the practice has an idea, so we'll call them the innovator, so they have a suggestion for how to make the clinic operate better, I can tell you who within the practice is always behind schedule and is always pressured by time, and it, in a way, is a resistor to any kind of change because they're kind of in their own universe when it comes to doing their practice. Implementing new things is difficult because they're never actually on time. I can also tell you within our practice who I would refer to as the whistleblower. So this is the person who at every board meeting will probably take up about 20% of the airtime in terms of who's talking. And she will sort of verbally tear apart everything that is presented in the board. And it comes across as being negative, but generally what she's doing is really processing. But a lot of people listen to what she has to say. I can also tell you who is just generally resistant to change for no good reason. So in quality improvement language, we would refer to them as a laggard. We also know who else is overwhelmed and really needs some help with how they do their practice. And so is stressed out but is otherwise open to new changes. And then I can also tell you who in the practice is the visionary. So who's the person who has the good idea of what the practice should look like in 2 years and 5 years and 10 years. I can tell you who the cheerleader is. So the person who's pretty happy that somebody is working on quality improvement, primarily so that they don't have to, but also so that they're getting new ideas about how to do change within their practice. And I can also tell you who is the thinker. So the person that most of the practice listens to, in quality improvement language, this is referred to as a prophet. So these are all different personalities that you'll need to consider when you're doing a quality improvement change, that these are people that you may need to engage to refine whatever ideas you're having, and then also to figure out where there may be pitfalls or places where you get stuck. And then there's the rest of the practice who is mostly just going along, doing their day-to-day job, and are listening for these other people to help them decide how the change should be implemented within the practice. In addition to the providers within the office, though, it's important to remember that whatever you do quality improvement-wise that changes something in your practice is going to influence or affect other people within the practice. And those can create individual drivers or barriers to change. So if you consider the rest of your staff, your nursing staff, front desk staff, lab support, administration, quality improvement projects are often designed in a way that would help other work groups within your office to improve what they're doing. But at the same time, you need to make sure that you're involving and informing and consulting these different groups. And that always means when you're doing quality improvement that you need the engaged participation of non-provider office staff. And that's why in the PCPCH standards, it really talks about a multidisciplinary team for quality improvement. I think it's also important to think about to what extent cultural factors like team dynamics or differences in approach between departments affect the success of change. As I mentioned, in my office we have 2 sites, and each site has 2 modules, and each module has 3 or 4 groups of people who cover for each other and work in what we refer to as a buddy system. And so each of those practice teams within each module and within each site do things a little bit differently. And then translating from one site to another site in terms of quality improvement changes can often be difficult. And so you have to kind of consider these things ahead of time. So moving on, if you remember those 28 providers, we have a staff of then about 100 staff members. And we have similar personalities and leaders within that staff. So I can tell you who within the staff is the hardworking, dedicated people who other nursing staff or other front desk staff look up to for advice and really listen to when it comes to doing new things within the office. I can also tell you within the staff who is overwhelmed and is kind of always putting out fires, either of their own making or trying to put out other people's fires. I can tell you who within the staff is more or less punching the clock, and so they're there to do a job but not as engaged in how the job is done. And then I can tell you who the really creative thinkers are who will sort of dissect and cut apart a workflow to figure out how to do things better. So it's important, again, to try to engage different members of leadership within the staff as well. And then the final consideration is we always see our patients as being consumers of healthcare and consumers of what we do within the practice. But really, when it comes to quality improvement, you want to try to do a shift and start thinking about that patient as being another prophet or another thought leader or another person who has great ideas about how the practice could be improved. And once you unify these 3 different groups of leaders, that's how you start to create a common vision for your practice. As I've mentioned, in understanding these different personalities within the practice, that's how you start to identify who the leaders are. And again, they're not necessarily people who are in formal positions of power, but they are the people who are listened to and respected by the rest of the staff. And so they have informal leadership positions. And these are the kind of people that you're going to want to try to engage when you're doing quality improvement. And so when you put together a multidisciplinary team, you want to make sure that team reflects a different range of stakeholders, so that you have your innovators, you have your visionaries, you have your cheerleaders, and you have your prophets in terms of the people who the rest of the practice listens to. And if you can effectively engage those different groups, then you have a pretty good chance of engaging the rest of the practice. The idea when you're trying to implement a specific change in terms of motivating the rest of the practice comes back to the analogy of the burning platform. And this is an image of an oil rig that is on fire. And the analogy comes from a specific incident, which I believe was in the North Sea. You can't tell, but these oil platforms are about 16 stories above the ocean floor. And during one fire in one of these platforms in the North Sea, people eventually decided to jump off of the platform because it was safer to jump into the unknown than to stay where they were. And so when it comes to quality improvement, we use that analogy to sort of convey the idea that we're trying to make leadership is trying to create a sense of urgency and a little bit of dissatisfaction with how things are being done. And that's how we generally motivate people to move forward with change. And leadership, I think, in general, and this again is mostly coming from the idea of the informal leaders in terms of people who are respected within the office, are really what's going to drive forward continuous improvement. And leadership, in our experience, involves inspiring other people, facilitating and supporting change, helping to develop staff members and other providers in terms of having clearer skills in quality improvement or in whatever it is you're trying to change, and then acting as a role model by being the people who are willing to make that jump first. In our Medical Home Learning Collaborative, which we ran for 2.5 years and worked with 8 different practices in Oregon, and then worked with another 13 practices in 2 other states, we promoted the idea that there are really 3 major things that you need to do if you're trying to implement medical home and sustain your improvements within a practice. And this comes from Carl Cooley's work. He did a national learning collaborative on medical home. And really the ideas that were key for transforming practices, one is understanding your population of special health needs. And the second is to gain family participation and feedback. And the third is to develop practice-based care coordination and the use of care plans. And so really in the 3 key factors that predicted the practices that were able to transform themselves and to continue to change and continue to grow, one of the key factors was successful engagement of families in terms of integrating families into quality improvement efforts. And I like Don Berwick for a lot of reasons, but he refers to himself as an extremist when it comes to patient-centered care. And his 3 maxims that he talks about in his article from Health Affairs is first, the needs of the patient come first, and the second, nothing about me without me, and the third, every patient is the only patient. And I think when it comes to quality improvement, the second one is particularly important, that anything that you think about changing in a practice is going to affect a patient, going to affect a family. And so you really shouldn't be doing any changes without the family's input and without their participation. And we're stuck. And my slides are not advancing, and I don't know what's happened. There we go. Okay, sorry about that. All right, so again, I'm a pediatrician, and so my bias is in terms of engaging parents in quality improvement. So when I use the word parent, just remember that this applies to any patient that you're trying to engage. And so these principles, these next couple of slides, are adapted from a document on the Center for Medical Home Improvement called Parent Partners, Creative Forces on Medical Home Improvement Teams. And I have the full web link towards the end in the reference slides. And they talk about 5 primary steps for adding parents or, again, patients to your team. And first is embracing the idea of a parent partner. Second is discussing the characteristics, traits, and qualities that you're looking for in a parent partner. And then selecting the partner, inviting and compensating the parent partner, and then replacing a parent partner when necessary. And I think that the idea of a parent partner or of a patient partner, somebody who's actually going to be an active member on your quality improvement team, is challenging for a lot of providers, because we're sort of used to keeping this veil up, and whatever happens in terms of our practice operations, we're not comfortable airing dirty laundry. And so it's important to really talk this through ahead of time and understand what the benefits of an engaged parent partner are going to be. It's not ever a good idea to just recruit one and throw them into the team and see how everybody responds. You want to make sure that everybody is on board first. And really, it's important before you have the parent partner or the patient partner come in that everybody is really committed to that concept. Discussing traits and qualities, there are some important factors that you have to think through in terms of what type of parent or what type of patient you want to have involved. Obviously, you have to have someone who has the time to commit. So for us as pediatricians, again, that means that they have access to childcare, or they have time when their kids are in school if you can meet at a time that's not first thing in the morning. You want somebody who's confident and able to speak up in group settings and that fit in with the rest of your group. But also it's important when you're thinking about quality improvement to think about patients or parents who have special health needs, because they're going to bring a very valuable perspective when it comes to medical home. The patient who comes in for a well visit once a year and otherwise you never hear from probably doesn't experience the practice or the care coordination efforts that you're putting through in the same way that somebody who has special health needs would. It may be valuable as well to think about multiple partners who have different experiences, because you'll get an even broader and more rich parent perspective. Selecting a parent partner in terms of how you do it, there are a couple of different ways to go through this. When we were starting out in my practice, we had each of the providers come up with a list of 2 or 3 names of potential people, either because they had the conversation in their one of their office visits, or in their experience this person has had a lot of input or feedback about how the practice is being run, or that they have experiences that might be valuable to a quality improvement team. And then we ended up taking that list, and our care coordinator sort of canvassed to figure out who could participate and who would have the time and the willingness to do it. Some alternate strategies would be to put up signs in the waiting room. We also put a blurb up on our Facebook, for example, just sort of saying that we're looking for family partners. And then we met with those people to sort of see who would be the best fit and who had what we thought was the best advice to offer us. I think it's important to remember to compensate your family members, because you want to have them on the same level as the staff and the providers. I mean, generally, if staff and providers are being compensated for their time, then so should the parents. And certainly for us, parents who are having to pay for child care, it's not entirely fair, I think, to expect them to pay for child care on their own. So we actually pay ours $20 to $25 per hour for their time and effort. We do a strategic onboarding process as well. So we talk them through about, okay, so here's how the clinic operates in terms of what the scope of our quality improvement committee is, but also how we make decisions and how that fits in with the board of directors. We talked about medical home concepts in general, and then we talked about the specific projects that we were working on. And then we also, for us, are able to connect our parent partners with other practices and other parent-to-parent resources. Specifically through the Oregon Center for Children and Youth with Special Health Needs, they have a lot of resources for parent partners. We haven't had to replace parent partners yet. For us, we've had the same one for the last 2 years, I believe. But it's important to consider that will eventually need to happen. And so keeping a list of potential parents who might be able to participate in the future is an important consideration as well. All right, so the second concept is about building healthy QI habits and making sure that QI skills spread throughout the practice. And the idea here is really making sure that the QI team is functioning well. that there is a clear mission statement for the committee or a purpose statement for the committee, that the committee also has clear avenues for sharing project information, goals, and aim statements with others. And so understanding, again, what committees or what meetings we need to be on the agenda for. So as the chair of our QI committee, I am on the agenda for the board of directors meetings every month. We also have some of our members who are on the agenda of the staff meetings every month so that we can easily spread what we're doing to the rest of the providers and the rest of the staff. We also are pretty intentional about having a bulletin board up in each waiting area so that we're communicating things to our patients as well. Not only what we're working on, but what we've been successful with, and then some avenues for parents to give feedback or ideas if they have suggestions for changes. I think the second thing that QI teams need to think about is how you do your pilots. And oftentimes, particularly for a practice my size, but I think it's true for everyone, if you can get a couple of early adopters to do a small test of change before you do a clinic-wide spread, that's going to help facilitate how well things are adopted. And really what we try to do with our pilots is not only test different processes, but try to figure out from those different stakeholders and those different personalities how things are going to work best. So it's one thing for a visionary and an innovator to come up with a pilot, but the people who are overwhelmed or who are generally resistant to change are going to have some pretty clear ideas about how a change is going to happen before they're willing to accept it. So again, going back to those personalities that we talked about a little bit ago, who are the people who you need to really engage in a pilot to understand not only how to be successful, but how to avoid failure. I'm going to skip this one on interest of time, but just to keep in mind that there are some specific factors that help to support sustained change, and I think the culture of openness and transparency and the multidisciplinary team are the two top priorities for a QI team. And then, again, to make sure that you're communicating well with your staff and with the other providers about how you're implementing changes and what changes are going to take place. And then in terms of getting down into the durable infrastructure for quality improvement, and I think that one of the things that we had to face in our practice is that we'd had a long-standing quality assurance committee in our practice, and so how did that fit in with the idea of quality improvement? And so I think many providers who have been around for a while are used to the idea of quality assurance, which really is a reactive approach to quality. So when there's a problem, the quality assurance team in our office would sort of look at, what's wrong, and is this an individual problem or is this a system problem, and would implement some kind of academic detailing, meaning, doing a journal club or bringing in an outside speaker to sort of say this is how things are supposed to be done in terms of aligning with guidelines. But quality improvement, on the other hand, really is a more proactive approach. So it's kind of figuring out if you're at a particular starting point, where are you trying to get to? So what's your end goal? And really is motivated by a desire to continuously improve processes to perform at the highest level possible. In a way, quality assurance can inform quality improvement if QA identifies that there's a system-level problem that's causing people to not perform at the level that they should. And so there is some overlap in our committees in terms of we have a member of the QA committee who sits on our QI committee so that there's communication back and forth so that we can make sure that we are coordinated in terms of what we're doing. And again, in terms of what a quality improvement committee should do, and this is how I sold this to our board when we were trying to decide whether, how much effort to put into quality improvement. The medical home transformation is really about broad systems change rather than going after individual providers who aren't performing at a certain level. And so assessing and improving the practice based on recognized medical home definitions requires some quality improvement. We also spend some time looking at the policy changes and health reform changes and how that impacts the clinics. And again, finally, the idea of not having quality improvement skills living in a single individual building adaptive reserve is one of the primary goals of a quality improvement committee. And that helps other providers and office staff to be competent in quality improvement. And then we also have other staff who are doing what we refer to again as sense making. And that's a skill that really needs to be fostered within a practice. So adaptive reserve. And this is defined as the ability of a practice to be resilient, to bend and thrive or survive under force, and facilitates adaptation during times of dramatic change. And this is really more predictive of a medical home transformation, are characteristics of the practice themselves in terms of, do they have the bandwidth, in a sense, to implement new quality improvement changes. A practice that is completely tapped out with no structure for quality improvement and no process for how to implement new changes is going to struggle. That would be a practice with low adaptive reserve. A practice with high adaptive reserve has an infrastructure, has resources dedicated to quality improvement, and has a specific plan for how quality improvement is going to be done. Sense making, and that, again, going back to Don Berwick, is defined as the process through which fluid, multi-layered world is given order, within which people can orient themselves, find purpose, and take effective action. And when it comes to quality measures, sense making is really the idea that a data point or a number actually can tell a story. And one of the things that we've tried to practice a lot in our quality improvement committee is to look at a specific data point, either from an external measurement from Quality Corporation or from one of our health plans, and say, what's the story here? Why is the number where it is? And once you can give the data meaning within a practice, an action plan becomes a simple next step. And so I think that doing that sort of group-level processing of data is an important function of quality improvement teams. So in terms of the structure itself, again, a multidisciplinary team is really necessary. So our quality improvement committee has nursing staff, front office desk staff, people from our operations team, we have a parent, and then we also have somebody from our tech staff. And really, it's the best way to ensure that clinical processes are improved broadly across a practice. Within each meeting, we determine clear accountability. So when we decide that we're going to do a particular project, we know exactly who's taking which steps, what the next steps are going to be, and what the level of completion is going to be between the current meeting and the next one. And then for us, again, as I mentioned, we have we're on the standing agenda for board meetings, nursing meetings, and operations team meetings. We've also done some parent advisory committee so that we get a little bit broader parent input. And in fact, when you're working with parents and families, there are multiple ways to do it. So recruiting a parent partner or patient partner for quality improvement is one way. The second way would be to do focus groups where you have a specific subject that you're trying to work on. So for example, having a one-time group of parents who come in to review service needs for children with special health care needs. Parent advisory groups, which can also be subject to specific, but those are more long-term standing committees. And so for us, we have a parent advisory group that meets quarterly and oftentimes will help us with the sense making in terms of the data. So when we have a parent survey that's done, for example, and we don't understand some of the results, we'll turn that back to our parent advisory group to sort of say, here's the question that we're struggling with. What did this question mean to you when you were answering the survey? And it may not have been the specific family members that answered the survey, but they can get a pretty good a good idea of what the question was getting at and how they interpreted that, and that helps us with our sense making. And then also, again, surveys are another way to engage families and youth. In terms of strategic planning, I think this is an important part of quality improvement. We often talk about strategic plans in terms of the elements of running a practice, but a strategic plan for quality improvement considers the changes in clinical services or operations that need to be made. So if a practice has a lot of projects going on, how do those different projects connect to each other and inform the direction that the clinic wants to take? And what are the specific goals of the clinic that are related to improvement would be the key questions for developing a strategic plan. And we do ours as a similar SWOT analysis. So what are the strengths of the clinic's quality programs? What are the weaknesses? What are opportunities in terms of projects that we can join? Or threats, which, you know, certainly something like not having medical home certification might impact our contracting. I use another technique called a NOME analysis, where we think through on any individual project. What are the goals of the project? What do we need to make that happen? What are the specific objectives or details of that project, and how are we going to make that happen in terms of methods and the evaluation? So we have an IHI form that we use for components of our strategic plan. So each individual project that we're working on, we fill out this plan. And what you see is that it'll be a clinical area, so what specific subject we're working on. And then we'll have our aim statements listed out in terms of the things that we're trying to specifically improve within that subject. We have a timeline for when we want to have those things done. And then underneath that, we break down for each aim statement, what changes are we going to actually implement? What do we need to do to make that change happen? And then how are we going to know it's done? The person who's responsible, and then in terms of a timeline of when we're going to do those different components as well. So each of our individual quality improvement projects within the practice, we have this project planning form, and those develop into the different components of our strategic plan. And then in terms of tracking clinical measures, which I won't spend a lot of time on either, we get measures from a lot of external sources, so QCorp, for example, health plans. We also, for our practice, and I think it's important for every practice to think through, is what are the things that are important to you in addition to those external measures. So do the standardized measures that you get from external sources match up to what you're trying to improve within a practice, or is it something else? So for example, when my practice was working pretty hard on implementing maternal depression screening, there's no standardized measure for that, so we figured out how to look at it ourselves in terms of figuring out how many patients at the key visits were screened for maternal depression out of the total number of visits that we had. And what that does for us is feeds into our electronic medical record in terms of what fields we need to actually have providers complete in order to get good data. And so what we've done is whenever there's a quality measure that we're interested in or that we're tracking, that field in the medical record is a different color, so that providers are sort of highlighted, okay, this is something we're working on, make sure you get the answer to that particular question. So that's a lot of material that I've covered, but I'm going to turn it over to Jenny at this point so that she can spend the rest of the time talking about how she has implemented these different concepts as well. So Jenny, over to you.
Thanks, RJ. I always love being on webinars and conferences with RJ because I learned so much, so thank you very much. I'm not sure how to advance slides.
Anna, are you going to turn it over to Jenny, or do you want me to advance them?
We'll move them. We'll turn it over to Jenny.
Thank you.
Okay.
You should be able to, there you go.
There you go. Okay. So, so I am in Salem at Child Health Associates of Salem, which is a private pediatric clinic. We're up to 9 pediatricians and 7 mid-level providers, and we run a very busy, active practice here. We've been involved with some OPIP learning collaboratives around medical home, and RJ asked me to talk a little bit about our QI structure and how we've involved parents within that. So here we go. So the primary way that we've involved parents is with what I termed, and it may need a new name, I'm not sure, is our Medical Home Steering Committee. And we started this as a committee, a multidisciplinary committee, including parents, that meets quarterly. And we just had our 6th meeting, so we've been at it for about 1.5 years. The goals of the committee, as we set forth with the first 2 goals, and then we added the 3rd goal as we refined our QI process. But the goal was a formal mechanism to integrate patients and families as advisors of quality, safety, our program development, and our educational improvement activities. And then the goal to disseminate this as a clinic-wide improvement strategy, again, with the goals derived from quality measures, as RJ mentioned, patient feedback, and multiple projects, and then the feedback loops from those. What's working, what's not working, what do we need to change? And then, kind of on the same timeline, we as a clinic have evolved more to team-based care, clinical teams. Our group divided into 4 clinical teams, and so the Medical Home Steering Committee has served as a forum for those teams to talk about their projects and their successes and failures, and help kind of spread what they've learned. Our committee meets quarterly. We don't have a big conference room at our clinic. We're a little tight for space, so we actually meet over at the hospital, and they have some meeting rooms that they allow us to do, which is nice. It's a nice, comfortable conference room. We serve lunch. On the agenda typically are kind of updates on what's going on at the clinic, what the new projects are. We did a little bit of remodeling, so we talked about that. We review ongoing QI projects. We review any new data that's available, and at the most recent meeting we had the results of the CAP survey. And then the teams give their reports, and we talk about kind of any new business or new projects that are going on. The committee is made up of representatives from all the departments here. Our clinic has kind of a downstairs clinical area and an upstairs non-clinical area, and so the upstairs people from billing and medical records and scheduling really help us avoid a lot of pitfalls in working on new processes, because they know the back end and they can help us head off a disaster in many cases. And then we have the representatives from kind of all of the levels of the visit downstairs, the MAs and RNs, providers, including our interpreters and receptionists. And so we tried to kind of walk through a patient visit and think about all the people that would touch that patient from the time they schedule to the time that the bill is submitted and paid, and to see kind of involve all levels. Right now we have 5 parent partners on our committee as well, and I'll talk a little bit more about who they are and how we've recruited them. And then representatives from each of the 4 clinical teams. And our teams are made up of providers and RNs and MAs, and a couple of the teams have recruited receptionists as well. But we kind of purposefully made the representatives to the steering committee, not the providers. We find that we have a lot of talent in our support staff, and so we really try to tap that. It's been fun to see who has kind of risen to the top with an interest and some skills in quality improvement, and it's not always the providers. So our parent partners, currently there are 5 moms. They don't have to be moms, they just happen to be moms right now. They have a range of age of children. There's some toddlers up to kind of some late teenagers, and so that's been helpful to have their input on the spectrum of needs through childhood. Moms of children with special health care needs, and also kind of typically developing children. And they bring with them a range of kind of outside experience. It's been really fun, and they from their other experience, other than parenting these kids, have brought really kind of informed what we do a little bit. One of them is involved with our Autism Medical Home Learning Collaborative. One of them is an RN who does a lot of quality improvement projects at Salem Hospital. Another works with community outreach programs at the YMCA and has been helpful in kind of building some community partnerships. And another has been very involved in the foster care system, and also working through the education system. So they've been just a very rich source of information and experience for us. So we recruited these parents by each of the clinicians, as RJ mentioned, came up with a list of 2 or 3 that they thought would be really helpful, and we put it out on Facebook, and then kind of talked to whoever agreed to this. We did not do a lot of onboarding, and I think that would have been helpful, as RJ mentioned, and I think maybe we'll do a little retroactive onboarding just to make sure that that everyone's up to speed and help with new members joining the group. We do compensate them. We do $25 a meeting. The meeting's usually about an hour to an hour and a half. And our accountant felt like it would be easier to do a gift card, so we do Fred Meyer gift cards for them, $25 for each meeting. So some of the light bulb moments that have come out of these meetings, I thought I would mention a few of those just so you get an idea of things that happen. The first bullet, we were talking about access issues for children with special health care needs, because that was raised as an issue based on our first CAP survey that was done about 2 years ago. And so in this group kind of brainstorming, we came up with a what became known as an advanced check-in process for our most complicated patients and also for new patients. And so it was one of those situations where it was really great to have reception and scheduling and parents all together and saying, what would you need? What would be helpful? How can we make this process smoother? We were working on transition to adult health care providers and approaches with families and teens, and so they vetted a lot of our materials there. We switched to a new patient portal, and they gave us a lot of feedback on what they wanted to see on the portal, what it needed to be like for it to be useful to them. And then another great discussion that we had was screening for barriers to medical care. There was a questionnaire, and we weren't quite sure how it would go over with our patients, and so it was really wonderful to be able to run it by folks and have some really good feedback. So challenges, I think RJ mentioned really all of these, and so I don't think what we've experienced is anything new. We haven't, we're still very much a work in progress, and so some of these things we're still working on. Team building amongst all the different groups, that's a challenge, and we're getting better with that. It's amazing what sitting down to lunch together can do for building teams. Some of the staff was pretty uncomfortable talking about things where we're not performing well. I think RJ used the term airing our dirty laundry, but that can feel uncomfortable. And sometimes we get feedback from our parent partners that can be really difficult to hear. We use the IHI project planning form that RJ showed, and that has been a little bit challenging to get folks to use and understand that. We purposefully have placed one kind of QI visionary on each of the clinical teams, and so they're working to help their teams use that tool a little better. Access to data is also a little bit challenging. We have a very helpful IT guy, and one of my partners, Dr. Ken Carlson, is very good at running reports in the EHR. But sometimes it's a little difficult to get the right data to understand the story. And then I like RJ's sense-making terms, kind of sitting down together and understanding what all of these numbers and what all of these experiences mean when you put them together. So looking forward, we're looking at some subcommittees to work on different issues between the meetings, parent focus group to look at smaller projects, more team building, better data reporting, just building in more skills to understand how we're doing, and just clarifying our goals, defining our projects better is always a goal for the future. Okay, and I guess that's what I have.
So it looks like we've had a couple of questions come in through the question pane, so I'll go through those, and Kate, if there are any more that come through that we have time for, then let us know. But thank you, Jenny, for your insight and for sharing what your practice has been doing. So the first question, our practice is going through major staff changes with providers leaving and bringing new ones on. How can we get new providers excited about QI? And I think that's going to depend a little bit about if you're talking about new providers that are coming in from a different practice, or if you're talking about new providers that are coming right out of residency who might feel a little bit overwhelmed. But I think one of the things that would be an easy entry-level conversation about quality improvement is just going into detail about how things are different in the current practice than they were from the last place they were, whether that was at a previous practice or in their residency, and sort of see what they feel passionate about in terms of changing within the practice. I think that most of the providers who are coming out nowadays are very familiar with the maintenance and certification quality improvement requirements, and so I think the new generation of physicians have a little bit different view and generally are a little bit easier to engage. I think the other thing that most new providers probably need or want a little bit is to get a better understanding of how the clinic does things. So, you know, it used to be in our practice that being on the executive committee was how you learned the nuts and bolts of the practice operations, but I think that quality improvement offers that same sort of opportunity to really get a clear understanding of what you've just joined up with. So I think that there are a few different, I guess, avenues for getting new providers excited. Most of them are going to be a little bit more innately excited because of the requirements, and whether it's excited from a good perspective or excited from a nervous perspective, I think they'll be a little bit more engaged. But I think it's an opportunity for them to understand the clinic operations a little bit better, but also to figure out how the practice is different from what they're used to in the past, and to see how they can reconcile those sort of differences. I wouldn't probably engage a new resident or a new physician right out of residency right off the bat, because they're going to need to get on their feet before they get too far into it. But I think that personality will emerge within probably the first year in terms of understanding what they're interested in. The second question is, can a clinic manager lead these efforts if the physicians aren't as interested? And I guess the question I would bat back is whether the physicians are not interested because they don't think the practice needs to change, or if they don't have the capacity to run a committee, for example. And I think that if it's the physicians are not having the capacity, then absolutely a clinic manager can lead the efforts. I would still want to have providers engaged in some way. So if they're more comfortable attending meetings and giving input, I think that's fine. And I think that's going to be useful, and probably clinic managers would have a better sense of how to connect both the providers and the other staff members in terms of getting both those parties engaged. So I do think that clinic managers can lead the efforts as long as you have engaged participation from all of those groups. And then the third question was talking more about how we selected staff for QI teams in terms of whether we took volunteers. And for us, that's how part of how we did our QI recruitment within the staff. But I also talked to both of our site managers, who are the supervisors for the staff, obviously, and they were able to tell me who amongst the staff generally come to them with ideas or come to them with concerns or things that they think need to be changed. So they know the personalities of the staff in a place as big as ours better than anybody else. And so I think if you have a conversation with whoever is supervising the staff, and whether that's individual physicians in a small practice who might be supervising their nursing or their front desk, or if it's a site manager or another administrator, then you can sort of complement who you recruit onto the committee in that way, because you'll know from other people where the passions and where the interests lie. So we did, again, ask for volunteers, but then we had some specific suggestions from our administrative staff who said, this person would be a good nurse to involve, this would be a good front desk person to involve, and so it was a little bit of a combined effort in terms of who we, how we did our recruitment. So how do we get funding to pay patient partners? And so for us, that is just out of our operating budget. And so for our, to kind of break it down a little bit, again, we have one parent partner on our quality improvement team. We meet once a month, and then she probably has one other hour a month of reviewing documents or answering emails and so forth. And so for us, that's $50 a month. Not a huge amount, and so it seemed like something was manageable. When we have our family focus group, that's once a quarter. It's 6 people, about the same length of time, so you kind of get an idea of how the budget comes around. But it's for what we get out of it in terms of the input that we get from patients and from parents, it is well worth the expense. But that does come just out of our operating budget. And was there resistance? Not really. I think that it was a small enough budget item that, you know, people sort of said, well, at least you're not asking for a new EMR. So it was not a huge problem within our practice. So those are the questions that I had.
Yes, amazingly, you got through them all at 9 on the dot. We are quite impressed over here for sure. So we just want to thank everyone for joining the webinar today. These are some links to general QI tools and resources that RJ mentioned in the presentation. If you do have any last final questions, feel free to type them in right now. We'll still get them, and we can follow up by email. If not, we hope everyone enjoys their Tuesday. Please take the post-webinar survey, and thanks a lot for joining us today, and special thanks to our presenters who shared such great information with us.